whereas Parkinsonism and akathisia tend to be very distressing.
Now, you also told me that you have a feeling of restlessness.
Yeah.
And so that you rock back and forth sometimes?
Yeah.
This is a fellow who had been treated for Tourette syndrome for many years, with and without neuroleptics. He'd been on haloperidol, he'd been on Pimozide, but when I met him, he was off all of those and was on a low dose of risperidone, and actually had no movements at all. He had no evidence of tardive dyskinesia, he had no Parkinsonism, he had no tics, actually. And so I tried to taper him off the risperidone, and what happened is he became psychotic. It became clear, to me at least, that he actually was psychotic, which was why he was being treated with these antipsychotic agents. He actually had an underlying psychosis. And he had been on only risperidone for the last several years. When this movement suddenly developed, actually, suddenly meaning over the course of a few weeks, when his risperidone dose was increased.
It didn't come on all of a sudden. I just started doing it little by little. I do it sometime today too, but I don't know I'm doing it. My mom tells me because before I go to see Dr. Freeman, I always ask my mom, is there any new tics you want me to tell him about? And she does that for me.
It's interesting that this occurred when his dose was increased. Typically, when a person has tardive dyskinesia, you can suppress it acutely by simply increasing the dose of their neuroleptic. See, he had the opposite happen to him. That's hard to understand. We don't understand these syndromes very well, but certainly in terms of what we typically see, if a patient has bad TD and you need to suppress it acutely for whatever reason, say they have heart problems and their movements are so bad that you're afraid they're going to have a heart attack, or they can't swallow because their tongue is moving, you can just load them quickly with a large dose of something like haloperidol and then work on a longer-term solution while you at least quiet them down acutely. That didn't seem to be the case for him. In general, with tardive dyskinetic syndromes, usually we think that about half or more of the young patients who develop TD will have resolution if you can stop the antipsychotic drugs. We think that with some of the atypical antipsychotics that you can undergo a period of what one psychiatrist calls passive healing, that putting them on a drug like clozapine or quetiapine, which presumably don't cause tardive dyskinesia themselves, allows that part of the brain that causes the tardive dyskinesia to kind of get better on its own, that using clozapine or quetiapine is very similar to the motor part of the brain as having them off antipsychotics entirely. So that if this gentleman came to me with this movement disorder, I would say the treatment of choice is no antipsychotic at all. But then, of course, the psychiatrist says, well, he's treated for a reason. If he's not on an antipsychotic, he becomes psychotic. So you have to treat him. So the next best thing would be to put him on an antipsychotic that itself has not been linked to causing tardive dyskinesia, and that we believe may allow passive healing. Now, not everybody heals and not everybody has it go away, so it may not do anything. Keep your mouth open. Okay, that's fine.
I don't have much strength in this hand.
With the choreic disorders, the constant random kind of movements, patients either are unaware or underestimate how bad their movement disorders are. Whereas patients with tardive dystonia are very much aware of their syndrome. Turn sideways to me. That's right. No, that's perfect. Dorothy has these involuntary movements of her arms, particularly her left arm. But the major problem here was the arm and the axial dystonia, so that she's leaning backwards. It's just going by itself, huh? Can you hold your hands out in front of you? Both hands? During this entire time, her psychosis was completely controlled. But they weren't able to find any other medications that could treat her. And she was intolerant of reserpine. It induced a severe depression. She was placed on clozapine, which actually did nothing at all for her movement disorder. And the rationale for using clozapine was to allow this passive healing business and also hopefully to treat the tardive dystonia, but it really didn't treat the tardive dystonia. But when we added reserpine, she was able to tolerate it this time, and she became dramatically better.
Go like this.
So this is, I think, a year or two later.
You tap your foot. And the other one.
The thing to notice is look at her left arm.
Sideways.
Look at her posture. Look at her head.
Can you sit forward in the chair?
Now you will see that she's a little Parkinsonian, but it was a price she was willing to pay because she was so much more comfortable. In other words, she's not normal now,
Put your finger to your nose.
but she's so much closer to normal
Now the
that
other
even
one.
though she's a little bit further in the direction of towards Parkinsonism, I mean, this is dramatic
Down to the
benefit.
To the right. Yeah,
This
right.
is why people like going to movement disorders. You have the occasional patient who you can improve so much. And this is control. She wasn't cured
Walk back and forth
because
a little
8
bit.
years later,
Yeah,
she
just like
still
a
has this
sideways
movement
view.
disorder, and
Turn
when
around.
her drugs
Turn
were
around again.
adjusted, she's got it back again.
And turn around.